Well, we left the most controversial, current, interesting panel for the last panel. And the reason, of course, is we want everyone to stay till the end. But we have in the room, actually, 3 former OFDA directors. I'm glad no one noticed that, except for the 3 of us, because they would say that this is heavily weighted. And then we have Peter Morris, who's now has been the director for many years of health at OFDA. So the chairman, or the moderator of this panel, Ki Lu, who's up here, is now the chief operating officer of the International Medical Corps, but he is also the director of at GW, the Center on Disaster Management, or you tell us what it is. At George Washington University in Washington. So he has many hats, many hats. So, Ki, would you come down, please, and the members of the panel who are going to speak, please join us up here. And this is a panel on Ebola, obviously very current. What is interesting to me is the level of panic in the United States. I don't think we had 5, maybe 6 deaths. Not that any deaths are acceptable, but oh, Peter's moderating. I'm sorry. Okay. So, but what if we had 1,000 deaths in Texas? What would have happened? The entire state was transfixed with just a few cases. 1 death, 3 cases. Okay. So anyway, Peter Morris is actually one of the experts in the world on emergency health and invented a lot of the systems over the years that we use now that are widely accepted in the United Nations system and by other emergency management offices. And he's a very old, and not that he's old, he's young, a friend of many years who I trust implicitly. Thank you, Peter, for being here. And excuse me for promoting you to be the moderator.
But you see, I took it right away. Thank you.
Thank you.
Thanks so much. Just as an intro, my name is Peter Morris, and I work with the technical assistance team at the Office of Foreign Disaster Assistance. And a special thanks too to Andrew. I mean, you've already mentioned one of my points was that there are three former OFDA directors here. So and maybe even I know Bill was here too. So acting directors too during the time. So a couple things about OFDA, and you might ask, like, why am I here moderating this panel? And that's a good question. One of the things, prior to 2014 and the Ebola outbreak in West Africa, the humanitarian office at USAID, or the Office of Foreign Disaster Assistance, really did not respond to outbreaks. We saw instead that responding to outbreaks was the purview of the Ministry of Health, to WHO, to CDC. And it's since then, and since the outbreak in 2014 in Liberia, Sierra Leone, and Guinea, that we realized, and that we were deployed, that we realized that this will be in our future. And I think one of the big problems that we had initially was this was all new to us. When there is a so-called complex humanitarian disaster where you have emergency indicators taking place at the same time as a disaster, if there is a cholera outbreak or if you have a meningitis outbreak, when you're already responding to a disaster, we will certainly respond to that. But this was the first time we responded to the primary issue was an outbreak. So subsequent to that, and at the time Jeremy was running the office at that time, he more or less said, look, we have to prepare for the next time. So what we did in the health section, or actually in the technical assistance section, is where we started an initiative called IDAP, or Infectious Disease and Pandemics, where we wanted to make sure we worked quite a bit with Dennis's group to make sure we'd be able to respond to disasters in the future. I want to just, before I introduce our panel, and we're going to talk about the most recent outbreak, number 10, that's in in DRC, or the Democratic Republic of Congo, in North Kivu. I want to just talk a little bit about some of the differences in number 10 and number 9. Number 9, as you remember, is about May 8th, was an outbreak in Western Congo, and OFTA did not become involved in that because WHO, the Ministry of Health responded, WHO responded, CDC was there, and it was an outbreak that worked as it should. And I would say, too, that, and again, let me give credit to Jeremy, one of the issues that helped that was the bolstering of WHO, because after the 2014 outbreak, there was a clear indication that WHO, during the 2014 outbreak, needed to make more rigorous its response to outbreaks. And so OFTA was involved with other donors to both with money and with assistance, human assistance, to help them. And so number 9 worked just fine, except when, and that was May 8th. In September, I think it was September 1st, no, I'm sorry, August 1st, the outbreak was first declared for the number 10 for Eastern Congo. And so the difference in Eastern Congo was that there was an ongoing low-level intensity, which made it, for the U.S. government, a non-permissive environment, or so to speak, because when the U.S. government sends people in as so-called official Americans, we're under chief of mission authority, which means that if the regional security officer feels it's too risky, they can simply not permit you to go into that area. And so that was the situation we found ourselves in. Due to this insecurity, we were restricted, and because of that concern and because of the issue that it wasn't seeming to be resolved, or because WHO was there in a very robust fashion, USA decided to deploy a DART. And the DART is currently there, and it, along with its CDC, is also participating on this DART. And a couple things I wanted to just give. I spoke to the field this morning, just to give you a little update of where things are right now. First of all, tomorrow, Wednesday, the Director General of WHO is going to call a meeting of the International Health Regulation to reevaluate whether they should declare a PHIC, or a public health emergency of international concern. So, speaking to them, as of yesterday at least, there have been 216 total cases, 181 confirmed, 35 probable. The case fatality rate is 62%. There have been 4,195 contacts. 78% of those contacts have been seen since October 16th. 61 contacts have been lost to follow-up, and the issues of major concern with our people in the field right now are that there's what's considered a low contact tracing rate, low vaccination rates, community resistance to safe and dignified burials. The majority of the cases are in 8 neighborhoods in Beni, and then, of course, the ongoing security issues, and that response staff who do not speak Swahili or Kanande, which are the 2 local languages, are not well accepted in communities. What I'd like to do, first of all, is throw it out to the, first of all, introduce, we have Joseph Fair. I'm sorry. David Brett Major from USIS, Joseph Fair from Scowcroft Institute, Dr. Rigo from IMC, Emmanuel Ogogo from CDC, we heard him last night, Nigeria, and then Kilu, who is also both from GW and from ICMC. So, pardon me? IMC, thank you. I'd like to throw it out, first of all, to the ICM team. And what are your impressions right now from the field? And what are your, not only impressions, but how do you think it's going? And what do you think needs to be done?
Okay. Thanks, Peter. And again, thanks to Andrew and Texas A&M for inviting us and giving us this opportunity. It's always great to come back here. Andrew, I believe, was the administrator when I was the OFDA director, so it's good to be in front of my boss again. All right. What we're going to do is actually Joseph Rigo and I will kind of tag team this presentation to provide perhaps both a kind of a headquarters and field perspective as to how the International Medical Corps was able to kind of get on the ground, scale up our activities. And just to build upon what Peter had noted here, if you look in the back here, right, outbreak number 9 occurred back in May through July, which you'll see on the far left-hand side in Equator Province. And about a week after that outbreak was declared over, right, there was an announcement by the Ministry of Health that there were a new cluster of cases that occurred in North Kivu in Ituri Province, which is about 1,500 miles across towards the east. So this is a far distance here, and the International Medical Corps was responding at that time to outbreak number 9. And Joseph was out there as a technical advisor, so when this outbreak occurred, we quickly put him on a plane in Kinshasa, and his team arrived on the ground in Beni in North Kivu, I believe on August 7th, so about 6 days after the outbreak was initially declared. To date, the outbreak, there's been 211 confirmed and probable cases, and the MOH has noted there's been 135 deaths, right? So I'm going to kind of set the context and then kick it over to Joseph and to Rigo to really elaborate on what was happening at the field level. But where this region is, North Kivu and Ituri, this is right along the border with regard to Uganda, Rwanda, South Sudan. And it's right smack in the middle of a war zone. And this region here has about 1 million refugees and internally displaced persons. There's one particular group, the ADF, that's operating in Beni, which is the second wave of the epicenter right now, where over just in 2018 alone, because of the conflict, 500,000 IDPs were generated just this past year. So you kind of throw into the mix here where we see increasing trends with regard to community resistance. We see increasing trends with regard to insecurity. And as a result of that, the second wave of outbreak in Benitown is very concerning for us, where there have been attacks against WHO, against the Red Cross. Our teams were in lockdown for a while, though we are based in Beni. We built and operate a 20-person Ebola treatment center in Makeke. And at times, that team in Makeke were unable to return back to Beni. We're also building screening and referral units and providing training materials. And at times, because of the insecurity, the teams are not able to get out. So we heard reports here that with this kind of escalating challenges, right, the numbers in terms of tracing, access to probable cases, we're not able to get out there quickly enough. And this has the potential here, and we'll see what happens tomorrow, of being declared this public health emergency. So against this backdrop, the International Medical Corps, under the leadership of the Congolese government, which is doing an incredible job given this very complex environment, with support from WHO, with support from the Office of Foreign Disaster Assistance, we've been able to receive funding really to be able to get the infrastructure in place. The Ebola Treatment Center you'll hear from Dr. Rigo, we built this in less than 2 weeks. If you think about that, and Joseph will elaborate on it, in terms of what it took to, we had to build a road leading into the ETC. We had to source, deploy, train an 80-person team to be able to support the ETC. So it's been a massive effort where other actors, ALIMA, MSF, right, with WHO and the Congolese government, really are fighting an uphill battle at this point in time And it's good to kind of see a lot of the generated interest and publicity around this crisis. So let me stop there and ask Joseph to take over, because he was the first one on the ground for us in Beni.
So I was actually just thinking yesterday, it was quite ironic when I spoke at this meeting last year, I was just coming from Congo, and as I'm speaking this year at this meeting, I am just coming from Congo for very different reasons. One thing I will say about this outbreak, because I know many of you in the room are curious about how this outbreak may compare to the larger one that we saw in West Africa. I'll start with the good things. The good things are that you can find very few governments that are more prepared than the DRC for Ebola. They have a lot of experience with the disease. And we've talked a lot about leadership and prioritization of threats, et cetera, in this room today, but the DRC some time ago prioritized Ebola as one of its major threats to national security. So when Ebola is declared, the DRC teams, local teams from the Ministry of Health, are often on the ground anywhere from 48 hours to 72 hours later. And we're very lucky to have that resource in the DRC government. I would say also they're very well versed in incident command systems and setting up and operating emergency operating centers. So this is a very different context than if you were going into a place that had none of those things. The other comparisons I can make are that with this outbreak in particular, all of the complexities that we talked about, resistance by the community, problems with burial, problems with communications, that's every single Ebola outbreak, and those complexities always exist to a varying degree. But throwing on top of that we're doing this inside of a conflict zone adds an incredible amount more complexity to that. And when we talk about a conflict zone, we're not talking about one party against another. We're talking about many different various factions all fighting for different reasons, some of them not necessarily political and just out for more or less piracy. So that makes our work very much harder to do, but I would say that we have hope in DRC just because the country is so well versed with the virus. As you mentioned, there is the language barrier, but I feel like that we're making progress on that, and it didn't seem to be as much of a problem as we thought it would in the beginning. I still am very concerned that we are seeing a very sustained amount of cases, especially in urban areas. What's important to keep in mind is that these urban areas are very connected to other major urban areas in other countries that happen to share the same languages. So if you're sharing the same language, you're sharing the same trade, et cetera, you're all part of a greater tribe. That is what happened in West Africa that we didn't really take into account in the beginning. We were looking at borders on a map and thought, oh, well, it'll stop there. Those borders were purely artificial and colonial in nature. So we have a very similar circumstance in this area. So I wouldn't say that I am confident that it will be extinguished immediately. I still think we'll see cases coming in. I don't know if it will turn into the great pandemic that we saw in West Africa. I think that's one of virology's biggest mistakes, to ever predict what it's going to come out like. That being said, I think that right now we have very aggressive efforts on the ground. A lot of players that weren't always part of the system, UNICEF, other big organizations that weren't always standard parts of Ebola response. Having them there and having that UN infrastructure that has been built up over the years through the MONUSCO peacekeeping operation has greatly transformed our ability to respond, and I would say enabled it. Dr. Rigo, I'm sure you have a lot more to add to that as a local and as leader of the project.
Okay, thank you.
And just to let you know, Dr. Rigo is our country director in Guinea. He happened to be at home on annual leave. So, when this came to a point where we realized that we really did have to have a permanent structure at the field level, we picked up the phone and told him that we'd canceled his home leave and he was going to be the response manager. So he's been at home, but working ever since. So.
Okay, so thank you for the organizer of this forum for giving the opportunity to be part of this. And thank you to IMC leadership to allow me to travel all the way from DRC to here and to have this opportunity to speak. Just to complement what Joseph Fair was mentioning here, is that there are a lot of lessons learned from West Africa response that are being copy and paste for in DRC. First of all, let's talk about the vaccines trial. I know in West Africa that is something which initiated at the end of the outbreak, and Guinea was mostly interested, and the first result came from Guinea. But likely in DRC, we were able to implement the vaccines immediately at the onset of the outbreak, and targeting the frontline health workers, also the contact and contact of contact. I believe that for now we don't have any health workers contaminated within the ETU settings compared to what happened to West Africa. And my belief is that the vaccine has a big role to play in this. And I would say that myself and Joseph were candidates for the vaccine. The other thing is about the Mary protocol, because we're able to initiate some compassionate treatments for Ebola, and looking at some drugs like the ZMAP, the MAP114, the remdesivir, and for now, this also has been initiated at the onset of the outbreak. In West Africa, this came late, and I think through the number of cases we got in West Africa, on 28,000, only 71 patients were able to receive, were able to be part of the clinical trial in West Africa. But this in DRC, we were able to start this at one sort of the outbreak, and currently the Ministry of Health is very supportive on this, and every single ETU that is Ebola treatment unit that is opening is requested to adopt the protocol and implement the Mary protocol. And we are part of this. And we believe that it is helping to some extent. Also, it builds trust between the patients and the health workers to some extent. The other thing is that looking at 2014, there were a lot of struggles, like first to understand the Ebola, what are the protocols, what have to be met. I remember with IMC we had to sit down and start drawing down protocols, writing line by line what you have to do in these circumstances. But in these circumstances, we had already readily available protocols that could be quickly used, and that what we did, just pulling some protocols that were used in West Africa, bring them to DRC. And that thing is about the health personnel, because we had already some people who have been working on West Africa response who were already trained, and it was easily through the human resources roster to have them quickly mobilized to come to support the DRC in a small refresher training. They could be able to start immediately. That means in terms of the time we took to train people in West Africa compared to DRC, we had some time saving in terms of time, and this helps us to be more and more responsive. The other thing is that there have been some improvement in terms of the optimum standard of care, because some things that were not done in West Africa, like taking blood pressure in a patient, taking the basic laboratory like glycemia, that can be done now. And we improved, at least at some extent, the contact between the patients, the families, and even the care, to the extent that the patient can be now followed thoroughly throughout his time being in the hospital several times, and that also improved the follow-up of patients. But this set is not without challenges. As people mentioned, we have a lot of challenges, starting by security challenges, because Beni, where we are currently, North Kivu, in the east part of DRC, is well known for the EDF presence. And I recall every weekend we were having shooting, and on September 22nd, there have been a lot of killing. Almost 21 persons have been killed, and that was 1 mile away from where our base is, and 1 mile away from where the humanitarian community is. And this is something which is occurring in a way that you understand what is the trauma behind this, but still with this, people are still forcing and have at least the response being done. But this is saying that there are some communities where we don't know exactly what is happening in. And what my understanding is that beside the different pillars that we already have for the Ebola outbreak, there's an important piece that needs to be taken into account, which is the discussion with this militia. How can they be talked to so that at least in this period, at least they can be some retreat in a way that at least response can go on. Otherwise, my fear is that will assist to an escalation of the outbreak, given that in some communities we are not able to know what is happening in. So talking about IMC intervention, I'll say that IMC have been in DRC supporting this Ebola outbreak response efforts, starting from the 9th outbreak in Bandaka and now in West. And it was very easy for them to be with this mobilization because we had, from Bandaka, we had some resources available, and that means the movement was easy to be done because we had readily available resources. And my guess is that that when we look at some kind of how can we have like emergency response funds in order to be more responsive, because for this time I could see that at least most of the partners, most of the NGOs, even including the IMC, they were very responsive because there were some remaining resources from Bandaka response that could be quickly deployed to support the West Africa, the West DRC response, sorry, West Africa DRC response. But what we are doing currently is that, as I said, we are engaged on the different pillars of the Ebola response, and IMC is currently supporting 5 pillars, starting by the case management, where we have worked, we construct the ATC, 20 beds capacity Ebola treatment unit in Makeke, and this is what with a lot of challenges at the beginning. When we were talking about constructing it, I didn't measure how much work needs to be done. But starting with the recruitment of personnel, both international, nationals, and have them passing through a pre-deployment training and be readily available to start working. The availability of logistic material, construction materials, that was a very big challenge. In a way that at the beginning we had to even readapt our construction plan in a way that we thought that we start by tents, which could be shipped easily, but at the end we had to use locally available material because we couldn't avail the tents through any procurement center. And that's where we think that it's most important to think how we can have a stockpile of some of these needed items for any outbreak and have them produced regionally where outbreak may occur. The other thing is that under this Ebola treatment unit, we are collaborating first with the MOH and with the INRB, with the National Institute of Biomedical Research, and we are implementing first the many protocol, which is will be administering drugs compassionate treatment patients, but also we will be working with the NIH to some extent with the NRB to do some randomized controlled trial or randomized controlled trials, and this will start shortly. I think some discussions are going on the protocol, and we are glad that we are part of this. And besides the case management, IMC have been involved in IPC, infection prevention and control. That is starting by constructing screening and referral units, and currently we are targeting to construct 40 screening and referral units in 2 health zones, in Beni and Butembo, with different funding from WHO and from OFDA. And currently we have set a certain number of SRUs, screening referral units, 11, which are already functioning, and they have demonstrated really to be a barrier in a way that some patients, positive patients, have been stopped to enter the health facility through the screening and referral units. And I think is that we are providing training of health personnel on infection prevention and control, and this we targeting 800 health workers to train, and currently in Beni we have trained around 240, and they are already working in their own facilities to conduct the triage. And where we didn't have yet the construction not finalized, we have developed a soft model of triage where we set, where we provide first IPC material to different hospitals, but also we design the patient flow in the hospital, in the health facility, to allow at least to start the basic triage and teach people how to do the triage so that they can be, while the construction is ongoing, the triage can be done. And that is being done across the two health zones. And the other pillar on which we are working is risk mitigation, community engagement, and community mobilization. And this, because of the security reason, we prefer to work through a third party, which is a local organization, a CBO, and this is helping at least to bring people to understand what is the screening referral unit about, what is the process to count in the screening and referral unit, and what are the symptoms, the basic symptoms, so that at least, and encourage people to seek for health care when they are sick. And this is demonstrating its usefulness, and we are continuing building on those. And the other thing is that we are looking at continuing the surveillance, including contact tracing, and we have some discussion ongoing with OFDA currently to support these efforts. And we are targeting to do some discussion has been matured this morning, and we are discussing how we can do it in the two regions where we are currently working in two health districts, Beni and Butembo. So
Thank you, Rigo. And I'd like to, in the second round, I'd like to talk a little bit more about their community work. One of the things about tomorrow, when the Director General convenes this International Health Regulation meeting, they're going to just evaluate whether they should declare this PHIC, or a public health emergency of international concern. Part of the criteria for that is if it spreads in regions. Now, I wanted to ask David a question, because you were just back from Western Uganda, I think, and right on the border, and I just wondered what kind of lessons in preparedness that Uganda has done, and whether and the other question was, if they do declare a PHIC, number one, do you think they will? And number two, what would that bring to the picture?
I thought you were just going to give me the easy question.
No.
Thank you very much, Peter. Thank you to the Scowcroft Institute for, again, inviting me into an opportunity to talk a little bit with colleagues and think about these issues of pandemic risk management. These views are my own. I'm very happy to be here, but nobody anywhere would ever take an institutional posture for anything that I say, so be warned. And I did have the luxury of spending September in Uganda, courtesy of my university and our Center for Global Health Engagement. And I was spending most of my time in health centers in Western Uganda doing just what you were describing, Rigo, regarding thinking about patient flows, case identification, and how those systems work with them and their district task forces. A little bit of time with WHO and UNHCR colleagues at the DRC refugee settlements. In Western Uganda, there are at least, just in the area where I was, which were near Fort Portal, there are 2 such settlements that have 60 to 70,000 DRC nationals living, with 1,000 showing up every week. And we do tend to think about this issue of Congolese movement, but it's also true that just north of Fort Portal and just south of Fort Portal, there are robust tribes that have very strong familial and economic relationships across the border that are very healthy. But it does mean that there's a lot of movements and relationships there in many of the same ways that many of us experienced in West Africa in 2014 to 16. So that certainly is a challenge. When I spoke at a related forum in May, I took glasses out of my jacket, and I talked about how when you show up for a response, you're issued a pair of glasses, and the glasses are specially designed to make sure that you can only see people who work in the narrow lane of work that you work in, and you're not necessarily even see the people that work in the other places. And I was reflecting on that as I was spending some time in your neighbor to the east, and thinking, well, yes, but in preparedness, what's happened is the glasses actually have not been issued, and there are processes certainly in place. We often talk about, so if you look at the Global Health Security Agenda, there are these lines around laboratory capability and early warning and detection, and those systems are so incredibly important, but all screening fails, right? All screening and surveillance fails. That is its nature. It's incredibly important, but it always fails. In H7N9 and MERS and Ebola in West Africa, all 3 of them were actually identified by astute healthcare providers who said, that doesn't look quite right. And then they were able to take advantage as active participants in systems that are constructed. And so there's a huge difference between process and purpose, and I think that's vigilance. And so I think that's a challenge in preparedness. It was certainly true while I was in Uganda. They are dealing, as does DRC usually, in many of the countries in the region. I know We'll hear a little bit about Nigeria and their 4 recent pandemic threat epidemics here over the last year. And it is a constant challenge of prioritization. But also in this meeting, we've been talking a lot about incentives. And what does incentivize neighboring countries to really be vigilant and find their case, should they find their case? If they find their case and they decide that it is an emergency with which they must deal, then they must make hard choices against other pervasive threats about how they applied their resources. But if somebody else finds their case and comes with international pressure and resources to now deal with the problem, well, maybe they don't have to make quite the same choices and there are more resources present. So I found the preparedness environment just as complicated as the response one. It was an eye-opener for me. Public health emergency of international concern. So the emergency committee will convene, as you say, and make its recommendation. Ultimately, for those who do not know, it is specifically the Director General's privilege to decide whether or not to declare FAIC under the IHR. The existence of the pathogen, just like in the simulation, the existence of a novel influenza, that gets reported under the Figure 2 algorithm in the IHR, and that's just a reporting function. So what does the FAIC bring to the response? In some measures, it's really a social mobilization tool. It is not as though Peter's not spending lots and lots of hours dealing and promoting his colleagues in U.S. government to respond. They're going to do that anyway. It's not as though Uganda and Rwanda and Sudan and Kenya, we should not forget, are not thinking seriously about what this means for the outbreak to be poorly characterized still in Eastern DRC. I was discomfited with a reference that you both made regarding the number. So we call this number 10. It's probably number 50, right? It's just we've observed outbreaks that we care about to the count of 10. And so what happens when you're in a complex environment and you don't really know how deep below the water your threat actually lies? Prior Navy, I have to say it that way, to the iceberg reference. But it is a challenge. So social mobilization is a great tool. I really have no idea what the emergency committee will recommend. I thought that the West Africa epidemic was a disaster in late March, April, when I landed in Conakry in 2014, and it took 4 or 5 months for it to be declared as a FAIC, and it was astonishing in scale. But on the other hand, we've also declared FAICs as a global community that I'm not sure what the utility actually was. We did that in 2014 as well. So I don't know. It's a great question to which I have no answer.
Well, thanks. Dr. Ogogo, I'd like to ask you real quickly, just your opinion, because Nigeria just experienced a Lassa fever outbreak recently, and also there was a very tense moment in 2014 when there was a case in Nigeria. What would you see, which you were very successful at stopping, what would you see as the similarities, maybe the key drivers, things to keep mindful from your experience?
Well, howdy everyone. Okay. Well, it's a real privilege to be here. I want to thank the school for having us, be part of this very interesting panel, and I've learned a whole lot. Well, Nigeria was very fortunate in 2014 when there was a single imported case from Liberia, and a health professional pretty much sacrificed her life, Dr. Didavo. And just like you said, there was a case, it didn't seem quite right, and and when she stopped the patient from leaving, kept him, there was a lot of diplomatic pressures to try and get her to change her mind. However, she stood her ground, and subsequently, unfortunately, she also, fell victim to the infection. And there were a few other healthcare workers who also, unfortunately died. But there were certain things in place that helped the country really respond to it. First of all, we say that having come through Lagos, which had quite a well-established healthcare system compared to other parts of the country, that was an advantage. And also there were some investments that had been done already in the country, which kind of were leveraged on. So we had a field epidemiology training program. which had trained a few hundred epidemiologists. We had laboratory systems that had been put in place through the PEFA program. As part of the polio eradication program, there was an EAC that had been set up, which was quite well developed and resourced. And also, there was a surveillance system. So most of sub-Saharan Africa is meant to operate what's called the IDSR. That's the Integrated Disease Surveillance and Response System, which looks at 40 different conditions, as well as an unknown. So those systems had been developed, perhaps more for polio as well, but also generally looking at HIV, TB, and malaria. So some of those systems were in place and they helped. Having said that, I think one of the key things that was part of that response was contact tracing. The ability to actually identify patient, that index case, and then really track the contacts of these individuals. I think that was a key innovation that made the difference, as well as the fact that these patients had temperature recordings for the duration for the window period, and as soon as they were declared free, they were basically, that ended with them. So like you said, there was no vaccination and so on and so forth. And so after that, we have had quite a few other outbreaks. So in 2017, we had 2 outbreaks, an outbreak of meningitis up north. We had one a few years ago, but a completely different strain. Instead of Men-A that we had previously, we had a Men-C outbreak, and that led to the deaths of several hundred children and young people, and mostly around the northwest, northwestern part of Nigeria. And then later in the year, we had another outbreak of monkeypox, which was now, I should have had some maps up, more in the south, south, and southeastern part of the country. As if that wasn't enough, in January this year, we now had another spike of cases of Lassa fever, which is also a VHF. And that led to quite a few deaths. Over that time, we've tracked it, and our epi curve shows that obviously the number of cases has dipped, especially in the last month or so. But they've in that response, they've had to do contact tracing for over 8,000 patients. But the other factor that happened there was also death of healthcare workers. So one of the triggers that really led to people responding, really beginning to realize there was an outbreak and responding to it effectively was the death of healthcare workers, which started with the death of a doctor and a couple of nurses, who fell victim to the infection as well. So we've begun to realize that for us, Lassa fever isn't necessarily is more of an endemic condition with peaks. And the other question we ask ourselves is that, especially since we've been trying to build a stronger national public health infrastructure in the country, that our surveillance system may have become more sensitive, and perhaps we're finding more cases. Generally speaking, though, in terms of similarities, we had been, as a country, we had been declared free of polio sometime in, I think, about 2014 or thereabouts. But we had 2012 or thereabouts. We had a re-emergence of polio, and it emerged in the area of conflict. So in the northeast, where we have the Boko Haram crisis, where obviously you can't really, your surveillance system can't be effective. That is where we had a couple of cases of polio, where you can't really vaccinate children as you need to, where your surveillance systems can't really be properly, can't be effective. And I think that's one of the greatest similarities that we have with this outbreak in Congo. It's a very volatile area. It's an area that, if the crisis there goes far back to the Rwanda crisis, where you had cousins moving across the border, which is really not a border but just a line. So you have a huge concentration of refugees living in squalid conditions, being pushed against the elements, and of course, the interface between man and wildlife, narrows, because they're not having, in those camps, obviously there's problems with food. They have to go and still get firewood. They still, have to eke a living. So, So those squalid living conditions and that existential threat that they have from being, completely dislocated makes them vulnerable. And I think that's one of the key things, one of the key similarities. Another idea that we need to think about is the whole issue around the fact that it's a huge border community with several countries involved, and therefore really doing contact tracing is difficult. IPC health system weaknesses exist in many countries in Africa. So when you have a weak health system, people haven't invested in IPC, basic public health measures aren't being followed, you have a recipe for disaster.
Oh, thank you. I'd like to jump back to David real quickly because you remember in 2014 there was this amazing thing called ZMAP. And in one sense, when the American doctors and nurse who were transported back to Emory more or less changed a lot of our policy overnight, it seemed. And with the advent of medical countermeasures and also the outgrowth of vaccination work that was taking place in Guinea, I believe, worked out successfully. And so, David, just what would you think? Has this outbreak shown any sort of evolution in obtaining licensed medical countermeasures against Ebola viral disease?
Yeah, thank you. So for background, we do not have a licensed medical countermeasure against a filovirus in the US or Europe. It does not exist. And we have an emergency use authorization for the Merck recombinant vesicular stomatitis virus Ebola vaccine, which is the one that was used in Guinea for ring vaccination and has been used most recently now in DRC to large effect, has been discussed over the last couple of days. And there are a few different investigational therapeutics. The ones that are being explored, I think, in the protocol that you're thinking about, and they are the MURI products. So the WHO and partners in country have compassionate use protocols in place in DRC. They're starting to do it in the countries at risk, such as Uganda. In Uganda, it's both MSF and also actually a Defense Department funded pilot project out in Fort Portal for doing experimental therapeutic assessment. Both have protocols out there for compassionate use drugs. These are monoclonal antibodies like ZMAP, another one called Regeneron. I believe there's an NIH monoclonal antibody 114 that has some connection actually to DRC and development. And then there's a Gilead product called Remdesivir, GS5734. That's the one small molecule that's most in play and in discussion. If you had asked me this question at the beginning of the summer, I would say no. And if you had asked me at the beginning of this outbreak, I would say no. Yeah. It is interesting, finally, to see some movement on more structured compassionate use protocols in DRC. I've been very impressed by that. I've been impressed by NIH and them taking another look at the way they had done assessments of products in 2014 and making honest efforts to modernize that approach. And so I think all of that is very encouraging. But I think the lesson, Rega, is really your lesson that you talked about earlier when you said it started, we had this problem in East Kivu, or in Eastern DRC around Kivu. We were suddenly standing up in ETU, but we were involved in this problem before and had given it thought, and we had procedures in place with which to begin manpower development once we recruited people and we got money and logistics on site. It's no different with research. You have the same implementation challenges, and we're still behind in getting ahead on that. This stuff that's happening now, which is great, ought to have been in play back in May.
I'd just like to go back to that question of community resistance. I know that I've seen, there's some very interesting literature out by a group, I think it's Juliet Bedford's group out of London, Anthropologica or something like that, and about community, they've done surveys of communities and what are they thinking about, why do they resist? And I wanted to talk to, maybe I'll give this to the team IMC. How are you dealing with this now? Because these are lessons we talked about from 2014. I remember we thought, gee, we need more anthropologists. We need more people to tell us, like, why if the community would embrace it, then this would go quickly. So just any of your thoughts on that?
Yeah, I think community engagement is key in the response, and a lot of effort need to be done for community engagement, but this require a multi-sectoral coordination and collaboration. Like a lot of, there are different channels of communication and different level where action have to be taken. And when I look at West Africa during the election period and looking at where we are currently, I feel that discussion needs to be, besides discussion to the community level and using key informants, it's also important to look at discussions at a high level discussions, like at the ministerial level, but also at the parliament level. Like I believe parliament members being the spokesperson for the communities, if they are in between the communities and the humanitarian community,
Would this
they
be the
can help
national parliament or the regional parliament?
both.
Okay.
National and regional parliaments, if they are in between, this can help. And it is also detrimental if they don't have the right information and they tend to get biased. And that's also need to be, that means there shall be a big focus for community engagement, to be informed and then to be used to be able to disseminate. Okay. Okay. I mean, yes, so they shall be really involved. They shall be involved to some extent to be able to liaise with the communities and be in between the humanitarian communities, the response teams, and the communities.
Can I just add to that, right? You touched upon early in your discussion about OFDA not being involved initially in the Equator outbreak, right? And that Global Health and CDC and others were there. And we've seen with regard to this outbreak in North Kivu and Ituri province, where definitely a lot of the investments and lessons learned in West Africa paid off. I mean, I think WHO is a stronger operational partner than what we saw in West Africa. But there is now this movement towards specialization and really defining roles and responsibilities to a point where now it's extremely bureaucratic. So if I'll give you an example on the community engagement piece. We get our funding from WHO to build and manage and operate the ETC. However, community engagement is in the lane of UNICEF. So if we want to do community engagement, we can't use WHO funding to go into the community to raise awareness. And one of the lessons learned from West Africa to here now in the DRC response is that we're building our ETCs within the community. Right. So rather than in West Africa where they're out in the wilderness somewhere, this has the ability here is that after this outbreak is declared over, whatever the investment we're making, the community can actually use, right? Because it's within the community. But the problem is that if we're managing the ETC and we cannot go beyond into the community to explain what is happening behind these walls, how are we providing treatment, what happens here with burials, there's going to be mistrust that's occurring in the community. So as we're kind of moving forward and building capacity, the problem here is that we need to also be flexible. And having this arbitrary line here that says if you are managing the ETC, you cannot be doing community engagement makes no sense. And in line with that, I would be strongly urging similarly with regard to OFDA, right? As the lead coordinator for disaster on behalf of the USG, where in the past here, right, you have internally made this decision that unless these outbreaks occur up to the L3 PHIEC right, level, that others within the USG are going to really become more involved and take the lead. The problem with that is that nobody has the same structure and the ability to move as rapidly as OFDA. And the ability to be able to work with partners, to get resources in the hands of partners so that we can do the community engagement, that we can do the preparedness activities so that these outbreaks don't rise in L3, do not rise up to that PHIEC level. So definitely, while you are building and supporting CDC and others to be able to have that operational capacity, we would strongly urge OFDA to continue to be able to play this leadership role.
Do I have to answer that question? No, I mean, I think, no, thanks, Key. I think that we've had a lot of conversations with Dennis's group on this, and internal conversations too. A couple things. We believe in the international system, and we believe that the first responder should be a robust WHO. And that's one of the reasons why we've put a lot of effort into WHO. And also with that, we believe that, you know, our colleagues at CDC work with WHO on that. So we feel that hopefully it'll never get to a point where we, you know, have to make those decisions. However, with the same token, because of all the experiences we've gone through, we realize that in the future, we're going to have a stronger ability to respond to outbreaks, or it will now be in our portfolio, whereas it wasn't before. And in one of the efforts we're working with, again, Global Health will feed into this too. We're working to be able to build, I mean, it sounds so trite, build capacity to respond to outbreaks. So we're, in our new initiative for pandemic diseases, we are looking at how can we help the community build capacity to respond to outbreaks. It means working with local entities to respond to outbreaks. And at the same token, too, our DART teams were looking at what will it take, and we're using this as a lesson learned, what will it take to be able to respond with a DART team and response management team that is looking only at outbreaks. So, I mean, well noted, and we are moving forward with that. I should probably, do we have time to do questions? Okay, great. If you have questions, this would be a great time. Yes, Andrew.
So is part of the response, are you immunizing everybody in the area? What are you doing with vaccines, or are you not using it? Number one. Two, what is the effectiveness of the vaccine?
Okay, so currently, the current protocol is targeting the frontline workers. That means the health workers, people working in the ETC for vaccine, and also the contacts and contact of contacts for the vaccine. And talking about effectiveness from West Africa research, last time clinical trials, it has proven that if the vaccine is administered earlier, within the 10 days, the coverage is 100%. And that means the likelihood of protection, the protection can be on 100%. But the question is how long this protection is. That means a lot of research still need to be done to know how long this protection is for. But at least we are very hopeful and very thankful that at least we have the vaccine, and we are very comfortable taking it, and we are advising that all health workers and take the vaccine, and even all NGO communities around are taking vaccine for now. Thank you.
David, did you want to add?
Oh, did you want to first?
I just wanted to add to that, Andrew. IMC ourselves are not vaccinating individuals, so that's going to be WHO and the Ministry of Health that manage the vaccine itself, getting it where it needs to be and getting it to the communities that are the priority communities. So I just wanted to mention that. Dr. Rigo and myself ended up having the vaccine ourselves because as part of our just routine examination of certain facilities, we were walking in and we didn't expect to find any cases, but it having been our background, we walked into a smaller public health unit and happened to find a novel cluster of cases that no one had previously identified. So we ourselves decided to take the vaccine at that point, and I think it's becoming a major tool now that we did not have before. It just wasn't even in our mindset. You know, this is where we're in a little bit of unknown ground, because this vaccine prior to West Africa had really only ever been in one human, and it was a human that had an accident in a laboratory, and it was worth it to take the vaccine even though it had never been in a human rather than getting the disease. And then in West Africa it was rolled out on a much larger scale, even though all we had up until that point was really non-human primate data, which was 100% effective. And most Ebola vaccine trials are not 100% effective in non-human primates. So that's what we're relying on that data, and David probably knows more about the human follow-up since that time.
Yeah, so I agree with what you said. I agree with 95% of what you said. It is not 100% vaccine efficacious. It just isn't. And so we really don't know what that number is. But it's certainly true that early administration, as you say, makes a huge difference. And it's certainly true that it has been demonstrated to interrupt contact chains and chains of transmission. So it's a great emergency response vaccine. Early data, I think, suggests that you'll probably get 3 to 4 months of coverage. Nobody knows what the tail looks like. There are some very good experimental vaccines that might have more durable protection that are also under evaluation, but they've not been shown to have this interruptive capability that the RVSV vaccine has. But you also, in addition to the challenges of preventative misconception, which are definitely present with the vaccine, so kind of like surveillance systems and laboratories, it's incredibly important, but it's not the panacea that one might hope, right? There's also a real challenge with mobilization of the vaccine in the countries that have to prepare for potential expansion. And part of this is a numbers game of vaccine dose. And so Uganda was considering late last month a Muri protocol submitted by multiple proponents so that they could give healthcare workers for compassionate use of RVSV in anticipation. But they were not able really to consider yet compassionate use for ring vaccination because they're not an affected country. And the agreements that actually drive how doses move and where they can be stockpiled and how the money can be applied for the doses to be available require you to be an affected country, which is an artificial application of Western sovereign perceptions against the population movements that we talked about earlier. It's quite a challenge in that respect. And so we need some more of your poli-sci graduate students to give that some thought.
Yes.
So I think it's really interesting that we're talking a lot about science and policy and those approaches. But I'm really interested in what I think is something that really contributed to the problem in West Africa that I think is happening in Congo. That I've been working in Beni with Devil for the last 6 years. And I think there's a lot of distrust within the communities and there's a lot of suspicion for what's going on. And I'm wondering, what are the approaches for that? Because I had a phone call this morning with one of my colleagues, and they think that this is a conspiracy by international community to come in and make money off the NGOs. So I'm wondering what approach is being taken for that in Benitown and surrounding areas.
I could try on that one. First of all, that's a conspiracy in every Ebola outbreak. Every time I've been in one, locals that do not like their government for many reasons will say, our government's just doing this to get money. And I think that's part of our bigger problem when we talk about responding to outbreaks, especially in states that are so heavily dependent on constant aid. So we come into villages and areas where NGOs have been present for many years. They employ lots of people, they have new cars, they have offices, they have facilities, and they're there for a very long-term program. Then we have this new case of Ebola that will pop out, and we come in as emergency responders. We don't do a good job of explaining at the very onset, this is different. We're not the long-term aid program. We can't be here to negotiate with you for weeks over what you will get out of this deal, et cetera. And so I think that is a lot of it in the beginning because we tend to be more removed than, say, the traditional NGOs that are there long-term in the community. But something that made a very big difference in this outbreak that we did not see in previous ones, you had the director of WHO showing up in the very second week of the outbreak. That meant a lot to everyone, not just the responders, all of the locals, everyone else saw that if he's coming to Geneva with his whole team to be here on the ground in the EOC with us, it's obviously a priority for them, and you're here as responders and to help us. And that was very closely followed the week later by the CDC director and the EU ambassador. So showing very strong leadership commitment at those levels has helped. We're still going to face that problem no matter what with certain segments of the society there because frankly they've been lied to by everyone for most of their lives. So I think there's always going to be that. The only way we can overcome it is just in our actions and what they see.
Well, can I say something about that?
Sure.
Well, I'm not trying to do a traditional, I disagree, but I think you're right. But also there's the idea that we need to think about. We we spoke yesterday about, you know, trust in these circumstances. And there's, I was talking with somebody, there's this idea around really defining what health security means. And I think that should guide the terms of engagement when partners come into working countries. You know, whose health are you protecting, and whose security are you after? And therefore, the need to begin to help countries to have strong national public health systems is really necessary. You know, we do JEs, Congo did the JE, and if you look at the reports of the JE, they were weak on preparedness. You know, the fact was there. But that transition from doing a JE and knowing what the problem is, and then developing a national action plan for health security, and everybody falling in to say, well, we know this is the problem. You know, we know these are the solution. The JE team comes in and gives you 60 recommendations. And you know that these things, if you put them in place, you know, it will help. It includes, you know, discussions around risk communication. It includes things around legislation. So I think that that trust can never be built if, you know, the people if partners don't seem invested in making sure that the systems are built up. There's the idea around universal health coverage and the SDGs, and, you know, an alma mater and what primary healthcare system should be. We know these problems are likely to occur, but unless we function in a way that it shows that these are long-term investments that need to be in place. You know, if you had a primary healthcare center, you wouldn't need to build an emergency ETC. But so how can we begin to engage on that level? That's one point. And then the other idea, I guess, also is about community engagement. You know, the fact is that, you know, when we come in with science and we come in with policy, we don't come in with anthropology. And I think that's the other aspect of a lot of work that we need to begin to do. Those teams that go in should not just be scientists. You know, you need, you know, the people who think about behavior. For instance, the NCDC, one of the things we've been working is that we have this, apart from we have, you know, disease, so far we've been having technical working groups that are made up of all the partners. So when we responded to Lassa, for instance, everybody was in that room. UNICEF was there, IMC is there, and you know, it's a continuum. So it shouldn't be, well, my work stops here, yours starts there. It should be like, well, I'm handing you the baton at this line. So I think that's, you know, rethinking the engagement is so important.
Thank you. Real quickly, Jeff, then Andrew. Well, if I'm going to ask
Who wants to start with that
volunteers.
landmine?
Start with Key.
I think there's a lot more presence on the ground within the first 72 hours, right? I mean, they are deploying staff. The problem with that is the infrastructure in terms of what they do when they get on the ground. This is part of, I think maybe Dennis pointed out earlier in terms of, you know, the US government enables and supports the private sectors and others. WHO needs to understand its role when it gets on the ground, which is really to support the implementers. And having 300 plus WHO staff running around with their vehicles, okay, maybe is sending the wrong message with regard to the community in terms of who's doing what. So they still have to balance out having presence and then resulting in some sort of action. And I think that action still hasn't, that process is not well thought out yet to the point where they could be like an OFDA. So I still get back to, that's a good model here. OFDA deploys a DART team, they come, they assess But their primary focus is to bring the community of implementers together and immediately prioritize interventions and get the resources in the hands of the people who do the work. And that lesson is still far from where WHO is today, at least from my perspective.
Emmanuel?
Well, I think one of the major things is the WHO, the no regrets policy. The fact that they, are willing to engage without worrying about, what the repercussions will be. I think the challenge for me would be, going to a situation where they stand shoulder to shoulder with the country, which is what it should be, and do a hand-holding, if you like, for the, coordination mechanisms within the country, so that, the voice next to the voice of the country means that all partners need to sit down at the table, put their cards on the table, and then, have a unified front. And I think that will definitely make a change in the way that, how effective responses are.
From what I see on the ground, the way WHO is embracing the new initiative when it comes to vaccines, trials, and this MERI protocol, and even what you're talking the randomized control trial through the NIH, for me, I feel it makes a lot of difference, because when looked at what was in West Africa, there were a lot of people there were no interest. That was self-driven, organized-driven, but now we can see everybody involvement. I see when we go on a call, it's everybody on the call, and I see everybody engagement. For me, that's success, and I can see how things are moving faster. In terms of challenge, of course, we still have some challenges, like what we were talking about. It's difficult to be a technical partner, to be a financial partner in the same way. Like as Kilo was saying, at least WHO need to strike the balance and being directly implementing and supporting the organization themselves on the ground. But for now, I think that the tendency that they want to be doing both roles, the technical support and so being directly implementing.
Yes, so I think David and I will have an interesting perspective. Both of us have worked directly for WHO as well as often with them extensively. So for me, what I saw a big difference in the last 3 years is I think most people don't realize how WHO works. So WHO offices in countries essentially function like embassies reporting back to their country, right? So they're all reporting back to either AFRO or Geneva or both in some way or another. And the WR, the WHO representative for each country, is going to be of a medical background, but that is essentially going to be an ambassador. I think what we saw in the West African Ebola outbreak is those WRs that had no experience in emergency response or mass casualty disasters. That was not recognized at the headquarters level or acted upon at the headquarters level early enough to make a big difference. What you see now is immediately on the ground is you have incident commanders and emergency response personnel from WHO that are there supporting the WR and reporting back to the WR in Kinshasa rather than the WR being directly over the leadership. So to me, huge improvement. It's a 180 from what we saw 3 years ago with them. As far as improvements that still get to be made, and I think this is not just WHO, it's many organizations. So when we talk about a chemical disaster or a reactor meltdown, I don't think we'd ever think about, well, we need to think about how we can issue the contract, how we can get it out fast enough to get the responders there, et cetera. But we still do that with pandemics. So, or epidemics rather. It takes 3 to 5 days or 7 days, depending on the urgency of your task, for that to work its way through to the contracts to get you the money to move. That is a delay in epidemics that we can ill afford. And I think we're going to have to keep working over time to refine that and get it shorter and shorter and shorter to allow us to move very fast.
If you are ever bored enough on a long flight to read my book, I give a little primer on WHO right at the front. And I comment on this because it is true, I think, that most of us forget what it is. It is a ministerial cooperative mechanism for convening and facilitating access, right? It's a vehicle for trust. And it's also something that has to react structurally and in performance to the will of the member states by their vote and by their funding. And recall that after avian influenza and SARS, the member states told WHO to back off, and they became much more laissez-faire and allowed regional mechanisms within that agency, as well as some other agencies within the UN interagency that deal with disasters and emergencies, to allow more will at the regional level. And so now what we're experiencing, as you rightly observe, is the member states saying, well, maybe we're not going to tell you that we were wrong when we told you to stop doing what you were doing, but now we are going to blame you for having stopped doing what we told you to stop. And so that restructuring is part of that. I will tell you that the emergencies division, that for lack of a better word, that Peter Salama and Mike Ryan run, and they're both very talented, and those teams are talented, that was a merger that was actually 5 to 10 years in the planning between Keiji Fukuda's Health Security and Environment Cluster and Bruce Aylward's Polio Emergencies Cluster. And so it was an interesting sort of combination of resources. And so it is also interesting that in some places they are the implementer. So my experience with WHO as a seconded official was I went down totally expecting to advise and then being the only one there. And so there's this real balance between ensuring initial resources on site and facilitation while allowing transition in a setting of stability, and it's a hard balance. And I agree with you, it's a balance to be struck. But this is an engineering school. It's under damped motion. I'm sure it'll soar.
Andrew, then Chesley, then David.
Two questions. Did it make a difference that the WHO Director General was Ethiopian? One. Two, did you engage with the faith-based leaders? The one institution, or the institutions that are trusted in Africa, in most African countries that I know, are the mosque and the church. Did you go to get more community buy-in, to go to the pastors, the imams and the mullahs to speak at Friday prayers or from the pulpit on Sunday to say these burial practices don't work or there's a problem with them, we need to alter this? Because as I understand it, that's what IMC did through OFDA grants in West Africa. They went through the traditional religious leaders to alter the practices. They didn't do it directly themselves. Is that correct?
Yeah.
Right.
Yeah.
I'll start just by answering on the second part, and I'd actually love your opinion. I am biased, so yeah. I'll say that we did reach out through the religious leaders, at least in the construction photos that Ki was showing, in that area, which happened to be very close to the epicenter of this particular outbreak. We did reach out to a lot of, particularly the Catholic Church, because it happens to be the majority religion there. And we actually did have a visit from the Vatican. A cardinal came and blessed the community, et cetera. So that was a very powerful message to the community. Yeah. But I'd love your opinion on the Ethiopian.
And as I said, like we, in our community engagement components, we are engaging a third party, which is a community-based organization. This is a faith-based organization, because churches, they have a lot of churches, they have presence on the ground, and they are well invested in communities, even hard-to-reach communities, and it is easy for them to disseminate messages in those communities.
One of our major partners as IMC, I'll just note on that, was the Baptist Federation too. So both the Catholic Church and the Baptist Federation there was a very powerful influence. Yeah.
Just real quickly, I'm sorry, I'm going to have to, Dr. Agogo is going to give the concluding remarks, and he has to actually catch an airplane. So I'm going to have to stop it right here. So please,
Right.
the podium is yours.
Okay, so thank you very much. It's like I said, it's been such an enlightening opportunity to be with you. There's no time to summarize everything I've learned, but just a few ideas that have really struck me in the time that we've been here. We've talked a lot about collaboration, so multi-sectoral collaboration. We've talked about, the whole of government approach. We've talked about, a whole of society problem. We've talked about health security. But one of the things that I think we might need to think about is, what do those terms mean? They mean different things to different people. Perhaps, the white people that will come out of this might help us define what these terms really mean. In a way that, from one person to another person, to whatever your interest is, or whether you're a government, or whether you're civil society, whether you're an implementer, the WHO, we were clear what we, apples is apples, like they say. The other big idea that I would like us to think about is the transition between, or the linkage between, these big concepts. For instance, the SDGs that we're talking about. One of our colleagues talked about the linkage with SDG 3, 17, and 16. So We need to think about all these work that's gone into the Sendai framework, into the SDGs, into universal health coverage, or perhaps universal health security. What's the linkage between all these, and how can the investments that people make add up to ensure that these things work for the populations? Especially because these outbreaks are definite that they will happen. It's invariable. And the question will be that unless you have systems in place to prevent, to detect, particularly to respond, then you'd have nothing. So in terms of, just to quickly, in terms of prevent, systems, the whole, if you look at the JEE construct, that first bit talks about, having legislative systems in place, having the laws in place, having your One Health platforms in place. And from experience of several JEEs, these things aren't in place anywhere. They're on paper, they are great ideas, but how do we really make them effective and function? And I really loved the framework that the PNR guys brought forward. So we don't need multiple committees, but we need a strong committee that coordinates. And for us in Nigeria, our thinking is, where does it sit? Does it sit in the Ministry of Health? Just like you've had this discussion, where is the best place for it to sit? As part of the Redise project, they've been trying to implement, and sometimes it sits in the Ministry of the Prime Minister's office. That brings politics. If it sits in the Ministry of Health, perhaps it's not as recognized as it should be. So where should it sit? Perhaps, I keep talking about these strong public health institutes because perhaps they provide the third man that everybody can look up to and can build trust. Final idea that I would like us to think about is the whole idea of community engagement, risk communication, because epidemics are about people, ultimately. It's about, one person either doing something right or forgetting to do something. So I don't think people are deliberate always in terms of how these IPC systems break down. So perhaps there's that need for huge investments in healthcare worker training, in health workforce development to ensure that IP systems are in place, medical countermeasures are available, gloves are there, water is available, which might be beyond what we can do here, but which we still need to talk about as important baseline, basic interventions. Just like the commissioner this morning spoke that, if a pandemic strikes, what is going to really make the difference are the simple, basic public health measures and interventions. So we shouldn't overlook those. So, and I could keep talking, but I've got that flight to catch. So thank you so much. It's been a huge experience, and thank you very much for letting us share the stage with you.